Hello and welcome to Better Man Clinics, the podcast where we talk to actual experts to address the questions that men want answered, but are either too embarrassed to ask or simply don't know who to ask. Before we get started, I do want to caution that the conversations on this podcast are for informational purposes only. They don't represent a medical consultation, nor do they present medical advice to individuals. Rather, we hope that the podcast empowers men with the knowledge and confidence to address these issues with their healthcare providers. As with any medical or wellness issues, you should always consult with your healthcare provider before beginning any type of treatment or preventative intervention. With that being said, in this episode, we discuss penile injections for erectile dysfunction. Now, for most guys, treating erectile dysfunction means taking a pill. But what do they do if the pills don't work, or if they're not able to take the pills because of certain medical conditions or other medications they're taking? For many such guys, a reasonable next step has been to try penile injections. But how do these injections work? What exactly is involved with administering them? Do they hurt? What kind of risks and side effects are involved? And of course, do they actually work? To answer these questions and many more, we turn to a true expert. Dr. Arthur Burnett is a professor of urology at the Johns Hopkins School of Medicine. Dr. Burnett is the director of the Male Consultation Clinic at Johns Hopkins, a clinician-scientist at the James Buchanan Brady Urological Institute, and is the director of the Basic Science Laboratory in Neurourology at the Johns Hopkins School of Medicine. Dr. Burnett received his undergraduate degree in biology from Princeton University and his medical degree at the Johns Hopkins University School of Medicine. He completed his internship and residency in surgery and subsequently residency and fellowship in urology at the Johns Hopkins Hospital. Upon completion of his urology residency, he received an American Foundation of Urologic Disease New Investigator Award to continue research work into the regulatory mechanisms of penile erection. He has maintained an active laboratory in neurourology since that time. Dr. Burnett is recognized for being a world authority in the science and medicine of erectile dysfunction. He contributed original discoveries of the nitric oxide biochemical mechanism in erectile tissue, which actually paved the way for the clinical development of oral medications to treat ED, such as Viagra. Dr. Burnett has written more than 150 original peer-reviewed articles, along with numerous additional articles, editorials, and book chapters relating to his biomedical research and clinical activities. He is also the author of a brand new book entitled The Manhood RX, Every Man's Guide to Improving Sexual Health and Overall Wellness. And now, without further ado, I bring you our conversation with Dr. Arthur Burnett about penile injections for the treatment of erectile dysfunction. Hello, and welcome to Better Man Clinics. Today, we're going to be talking about penile injections for the management of erectile dysfunction in men. Now, for most men, dealing with erectile dysfunction usually means taking a pill, whether that's Viagra or Levitra or Cialis. A pill usually does the trick. But for some men, they can't take a pill, maybe because they have other medical problems that prevents them from doing it, or perhaps they're taking other medications that won't allow them to take it. And for still other men, the pills just don't work. So where do you go from there? Well, in a prior episode, we talked about penile implants, a surgical option for treating erectile dysfunction, but that's a pretty aggressive treatment, and it's also irreversible. So is there a middle-of-the-road treatment? Is there something between pills and surgery? Well, fortunately, there is, and one such option does include these penile injections. But what are these injections actually? How do they work? Do they hurt? What are the side effects? And frankly, do they work? In order to answer these questions and more, we're very lucky to be joined by a true expert in the field. Dr. Arthur Burnett is a professor of urology at the Johns Hopkins School of Medicine. And he's also the author of a new book about men's sexual health called The Manhood RX, Every Man's Guide to Improving Sexual Health and Overall Wellness. Dr. Burnett, welcome to the program.
Thank you. Delighted to join you.
It's our pleasure, and we're definitely excited about tapping into your expertise on this very important topic. I also want to definitely talk a little bit about your book, and so a lot of real estate to cover today. But before we dive into any of that, one of the things I really like to do at the beginning of the program is to have our audience learn a little bit more about our expert. So one thing I always love to hear is kind of what inspired you as a physician to go into urology, and specifically to focus on men's health and men's sexual health.
Oh, sure. Thank you, Oleg. And briefly, urology appealed to me as a subspecialty of surgery. Going through medical school, as physicians, we have to identify a specialty area, and surgery appealed to me, craft, especially that involves direct patient contact and perhaps seeing some effects fairly immediately as a surgeon, also having stamina and perhaps temperament to be a surgeon. But within that specialty, urology was a great appeal, and I just recognized that it offered a great deal for my participation as somebody who can see some of the ethnic basis of disease states that affect the populations in urology, such as prostate cancer in Black men. Also having a sense that this was an area that we can make great progress, including sexual medicine, and that's where I got interested in the field.
Interesting. Thank you for sharing that with us. Now, diving into penile injections. One thing I know that you're definitely an expert in, and some of the guys love to learn is really kind of how this really works, right? So we understand we're doing injections, but how does this medicine really work? What allows it to cause an erection in the penis?
Certainly. Well, Oleg, I made even preface by telling you how injections even got started. You may recall that perhaps in the early 1980s or so, at one of the American Urologic Association meetings, this idea of intracavernosal pharmacotherapy, or penile injections, was introduced by a British pharmacologist by the name of Yves Brenly, who actually gave a lecture to an audience of several hundred people, and actually had injected himself in the penis at the beginning of his lecture with agents that he had learned while studying this field of medicine. This had what we call vasoactive properties. That is, it could cause blood flow effects, and actually self-injected. And what could make a more significant impact at a lecture than actually doing a demonstration, show and tell, if you will. And he actually had self-injected, and beneath his more or less stretchy pants, his sweatpants, what have you, he actually walked off the stage, walked through the aisles, pulling his pants down, and the audience got a real view of what an erection looked like. And Oleg, if you had to give a lecture, you know that's probably one of the tense moments ever for anybody, get in front of an audience. So with all that adrenaline rushing, you would think nobody can get an erection there. Well, he had one, and it was a great demonstration of how this would work. So this introduced or almost inaugurated the field of pharmacology in sexual medicine, and we learned how drugs could work by an injection with a needle into the side of the penis, where you're delivering a medication that has effects on what we have now come to understand better about the science of erections and how drugs work and what are the mechanisms of penile erection.
Yeah, I'm not sure that demonstration would have gone as well today as it did in the 80s, but you know, there's a time and a place for everything, I guess, right? But
absolutely,
that sounds pretty amazing. Now, you mentioned that again, that these medications they allow blood flow to enter the penis. Like, how does that actually work? Like, what do they cause the blood vessels to open up? Like, what would cause a penis that otherwise can't get an erection to now get one with this medicine?
Absolutely. Well, you know, that was the amazing thing. You know, back in the 80s or so, in the world of sexual medicine, we were still debating really what made erections work. And I think we only really came to understand the science of erections around that timeline, because there were debates as to whether there's something that was making the blood vessels tighten up, which sounds intuitive because, get erection, something got to get hard.
Right.
But the story of the erection process that we learned was that blood vessels that feed into the penis, they are relatively tightened when we're in a flaccid state. And the blood vessels have to open up or vasodilate. And there's a mechanism for how that works. with chemicals released from nerve endings and some other chemicals that can get into the penis, and now replicated by drugs that make the blood vessels open up, feed the penis with blood, create a kind of an engorgement effect. The penis swells, and that's what an erection is, to a certain finite extent. And when it really swells to that maximal extent, that creates the hardness of an erection. And the basis of that is blood vessels opening up.
Got it. And, we had mentioned that, some men for whom Viagra, Cialis doesn't work, they can try the injections. Is understanding that the mechanism is pretty similar for these pills as for the injections. Are the injections just stronger because they're injected directly in the penis versus the pills that have to go through your whole system and be ingested, et cetera?
Well, terrific thought. The evolution of the therapy along the line of drugs, as you can tell, then with the oral therapy that came after injections. Mm-hmm. And the idea about the oral therapy was, how could you take something by mouth that would somehow find its way to the penis? Well, right. There's a real science behind these so-called phosphodiesterase type 5 inhibitors. There's a mechanism there that takes advantage of what we understand about some of the chemicals that seem to be very uniquely active in the penile area. But with injections, we have a greater range of drugs that can exploit various mechanisms that then can bring about the vasodilation of the blood vessels even more effectively than oral therapies may afford. Oral therapies work, but as you mentioned, not for everybody, and the injections may actually bring forward a couple of different options, taking advantage of other mechanisms than what the oral therapies can solely offer.
And so in your book, you actually really nicely broke down the different types of injection, because they're not, like, as you mentioned, there's not just one type of injection. We call it injection, but there's different medicines or combinations that you're injecting. Can you break down for us a little bit, at least on a high level, what those different types of medications are and maybe how they're different?
Absolutely. Well, as a follow-up on how we think about these mechanisms now, there are more than one about how the blood vessels can vasodilate. Mm-hmm. And therefore we can take advantage of that, understanding that a drug may target one mechanism, another drug may target another mechanism, another drug may target another mechanism. Mm-hmm. And if we bring them together, it can be a single form of therapy. We call that monotherapy, or we can combine these to even have a more potent effect. I kind of use with my patients the analogy of going to the gas gauge or the gas pump. And you can go to regular or high test, right. And then depending on what your penis may need, depending upon the extent to which your erections have been affected, you can use a single form of injections. And there's one drug we commonly use called alprostadil or prostaglandin E1 that typically is our first line injectable drug. But if there are combinations, 2 drugs together, that's called bimix. 3 drugs together is called trimix. So cleverly stated, there are these backup agents that work through other mechanisms. The other drugs, phentolamine, which works by a mechanism of also making the blood vessels open up, and a third drug called papaverine, which is another one. And again, for the audience, you're not going to memorize all these drugs, but just to understand, as you're saying, from a high level view, there's different drugs we use that work through different biological mechanisms that can bring about the effect. And we can elect to start with maybe just the regular, but if necessary, move on to high test and super high test if we have to.
So again, if we're talking about efficacy, the monotherapy, which is usually PGU1 alprostadil, is kind of like the entry-level medication, and then you go up one level with bimix, and trimix is even more effective or stronger, kind of as you work your way up the ladder there, right?
Yes, and is needed, and that's an important message, again, because as we implement therapy, what I commonly hear from my patients is it just one drug dose and that's it? No, it's a matter really of understanding the extent of the dysfunction that may vary between individuals. Some men may just need a whiff of medication. Some may need really the full super high test, and we establish what drug works to achieve an erection response that is usable, but is not going to be excessive, and that's key. So it's a matter then of really evaluating each man's presentation and then determining the right dosage.
Well, that's so important. And I have to double tap on that and stress that, because again, a lot of guys, they try to say, I'm going to go somewhere. Maybe I'll borrow my buddy's injection. He'll teach me how to do it. I'll just give it a try, give it a test drive before, I go to my doctor just to make sure it works. But as you're explaining here, it's almost like you're playing three-dimensional chess, right? On one dimension, you have to figure out what medication or combination of medications you're using. And another dimension, you have to figure out what dosage of that combination you're using. So it could be a little complicated. So it definitely sounds like you should be under a physician's guidance when you're doing this type of titration or working on the right combination and dosage.
Absolutely. And I think just for safety purposes, and we can certainly discuss this, but, a strategy is to really use the initial lower dose, maybe just the monotherapy, maybe with a test injection, even in the office, maybe just to make sure that the patient can be safe about it, understand the technique, and then also evaluate that patient's response. So those three things I check for. And then if necessary, then adjust, titrate upwards, go to bimix or trimix. If we know that the monotherapy injection just produces a weak erection response, and we know that man needs to have something firmer to be able to be active in the bedroom, then we can adjust them to the other higher combinations if needed.
Got it. And a lot of guys, they obviously they see, Viagra on TV all the time. They know it's kind of mainstream medication. Are these medications, these injectable medications, are these considered FDA approved kind of out of the box medications, or are they still considered experimental?
Well, good point. That's a loaded question to the extent that, in medicine, there are situations where there are drugs that are not necessarily FDA approved, but they're used in other indications. So we know they're safe drugs, although for the indication of treating erectile dysfunction, the only real agent that's been approved for that, to my knowledge, is prostaglandin E1 or alprostadil. So using the other ones are what we call off-label, but under supervision, proper dosing, and what guidelines have allowed us to do within our specialty. We can use these other medications either as bimix or trimix, understanding that they just have not just been brought forward, maybe by a manufacturer, to just go through their ideal approval processes to be FDA approved. But nonetheless, that does not mean that they're experimental. Right. These drugs have been in use now, as you may gather, for 30 plus years. And we have very good literature support for their use. They have been reported on in clinical studies, and I think we have a good wisdom about how to go about using them.
Perfect. Yeah, that's what I wanted to clear up. Now, I painted in the introduction, I painted a very clear picture here about using this. Well, if the Viagra doesn't work, then you go to this, or if the Viagra doesn't work and you don't want to try surgery, then go to this. But does it always work that way, Dr. Burnett? Or do some men just start with injectable therapy? Can it be considered a first-line therapy?
Well, very good point. And in fact, the American Urological Association, AUA, had commissioned a guideline panel, of which I was the chairman, and published a report here, and now about 4 or 5 years ago now, and we kind of reframed the thinking about this, because there was a thinking in prior years that each man had to kind of start with the least invasive, perhaps the simplest thing to use, and then work his way up the scale to more invasive, perhaps with more intensive or challenging interventions. We came to realize that we can individualize care better and not just be so simplistic. Rather, if a man presents with a more significant form of erectile dysfunction, such as a diabetic, such as a man who may have had a prior pelvic surgery like a radical prostatectomy for prostate cancer treatment or radiation, where we know that his erections are really almost non-existent. Rather than have that man be frustrated, perhaps with the oral medications that have been demonstrated to have limited efficacy there, maybe we can kind of move forward and say, okay, Mr. Jones, we may be more effective for you to find a therapy that really addresses your degree of erectile dysfunction. And if that's so, maybe injections offers that opportunity. So yes, I think we're modifying our process of how we go about the administration of treatments, understanding that man's understanding of the risks and benefits of the different treatments, understanding his preferences, understanding his disease presentation, and helping counsel that man to find the most effective therapy given his condition is kind of the new approach to managing erectile dysfunction with these therapies.
Yeah, I think that's so important for guys to know, right? So that they know that, you know what, it doesn't necessarily have to be that stepwise fashion, and just to know at the outset what the options are to really kind of make that informed decision for themselves. I think that's pretty important. Now, I mentioned also at the outset that, you know, some guys can't take Viagra because, you know, they may have maybe they're taking medication that's contraindicated with it, like nitrates, or maybe they have severe heart disease. Are there any such contraindications for injections where guys should not be doing injections because of some other criteria or things that are going on with their body?
Well, good point. I mean, certainly, um, with any intervention, we need to assess, as I mentioned, the risks and benefits. That kind of balance that goes on, and among them, risks are potential adverse effects that could occur. Not to mention perhaps just issues that the patient may acknowledge in terms of just the reluctance to use a therapy. That would be a negative, and so forth.
Right.
But you know, are there true contraindications? And I think we had formerly thought that any man on blood thinner should not be doing injections. That was a big no-no. Patients who may have had a risk to get prolonged erections or priapism, that this may also be a relative contraindication. MAO inhibitors have been listed there. Some of these are agents that are used in various ways for other psychosocial effects and this and that. But I think simply said, these medications we've kind of almost reconditioned our thinking over time. I think under supervision, all of these may not necessarily be true contraindications. And in my practice, realizing what we have for therapies, if a man's not responding to oral therapy, so therefore that's not going to, the lesser invasive option is not going to work. He's not interested in doing a surgery, which, as you mentioned before, is much more invasive and irreversible. You can't go back to other things.
Right.
And then there are limited options. And I think just under careful supervision, maybe in-office testing, very careful description of dosing, and monitoring patients, these other considerations that were thought to be complete contraindications are no longer, I think, really not necessarily contraindications.
Very good for guys to know, because I know I agree with you. In the past, somebody was on Coumadin or some other blood thinner, and it was just automatic exclusion. Where now it's a little bit more gray area but definitely needs to be discussed with a physician and really be done under supervision. Again, can't stress. Do not try this at home by yourself without supervision.
Yeah.
Can't stress that.
Well, the thought is, you know, you put a needle in yourself, are you going to cause bleeding? Now, as we discussed this, the injection needle here is a very fine needle, very safe to use if done properly. It's not even as big as a needle to do a blood draw in your arm. So the initial thought was, well, you put a needle, you can cause an injury, bleeding is going to occur, and bruising and this and that. Well, done properly, we don't really see these side effects.
Got it. Well, you know, since you brought up the topic of the actual injecting with the needle, can you walk us through a little bit in terms of like what is actually happening? First of all, first question is this something that a guy can inject on themselves on their own, or do they need to have a partner do it? Or is this something that's done in the office and then it works for months and months? Like, what are the actual logistics of penile injections for guys?
Absolutely. Well, you know, the concept here is that this is a treatment for erectile dysfunction. It's not really a cure. It doesn't really, at least as our understanding to date here, it's not really rejuvenating or curing the diseased penis. So really, it's a treatment that pretty much on demand is the term we use, that is applied to create an erection effect, meaning that you have to do the treatment in anticipation that you're going to get an erection and then be able to use that erection with sexual activity. So with that concept in mind, it would stand the reason that a patient needs to learn how to do this, either himself or his partner, and once taught, can then apply this at home, knowing that the injection response is within minutes after doing the injection. It's not an injection we do in the office and then expect you to go on home 45 minutes later, an hour later, and the erection's still there, because we only want the erection response for about an hour. So you really want to do it in a timely way, and therefore patient training with this, along with just the basic education surrounding it, the training to actually carry out the injection process is what's required. And it can be the patient or it can be a partner. But in any case, they need to know that it's done in such a way that it's momentary, or at least during that episode. If you want to have another erection, it's going to be another time you have to inject on another time, because it's just on demand for that episode.
Well, the reason I bring this question is, like, in my own practice, I've had guys where, we've sat and we've had the whole conversation, it's like 20, 30 minutes. Sometimes we go into all the details, the nitty gritty. And then at the end he goes, wait, you mean you're not injecting me in the office and then it works for months? You mean I have to do this every time? No. Let's talk about another option here. So I just wanted to clear that up, that this is on-demand therapy, right? That this is something that you or a partner have to do to yourself. This is not something that a physician is going to come to your house to do, and certainly not something you can do once and then it's going to keep working and working. So
absolutely correct. So that concept has to be conveyed, and if, in fact, indeed, that is perhaps an issue where some patients may have some reluctance to do this. Some patients say, I just cannot do needle shots on myself, and certainly in the penis. I'm not certainly in my 30-something year career ever seen a guy said who's happy about doing needle shots in the penis. But some do come in, do a trial session with us in the clinic, and they do say, well, I think I can handle this, and move forward.
So you said injection into the penis. Can you maybe, like, even with your finger, just show us like where it's injected? I mean, is this injected through the head of the penis? Is it injected like on the sideways? Like, just to give people context, like, where's that injection actually applied?
Sure. I mean, by way of demonstration, my finger represents the penis. The injection is done toward the base of the penis, off to the side. Okay, not at the head of the penis, where maybe a much more sensitive area. But it's an injection here with really a diabetic needle, which is really only about a third of an inch long or shorter, very slender needle, and it's done very smoothly and safely, where you inject the medication, withdraw the needle, hold that area just momentarily, just for a blood spot or two, and then erection should come about here within a few minutes. So really, it's a fairly straightforward process, to where it at least is as attractive as we can do it to inject your penis. That is where it's done. Hopefully in an area that can be handled.
And approximately, I know it varies from person to person, but approximately how much like actual stuff are you injecting? Like, is this like a large volume that you have to shoot into the penis? Like, what are we talking about in terms of amount?
Well, really, it's a very minimal amount. I mean, it's like the equivalent of a couple of, like a medicine dropper amount of fluid or something like that sort, if you can picture that for the audience. So it's really just a small amount of medication, and then you withdraw the needle, and that's about it. And then the medication itself takes its effect.
Got it. And so, you said within a few minutes, maybe 5, 10, 15 minutes, you start getting an erection. This is something that we talked about a lot during the penile implant episode versus the pills and stuff. Does that erection feel like a natural erection, or does it feel artificial because of this medicine working inside the penis?
Well, yeah, the observation I've had and patient responses have communicated that really resembles a natural erection. And in point of fact, really, that's just what the injectable does. It's a pharmacologic effect, drug effect, that really resembles the chemicals our bodies make. And now that we've understood the science of erections, it creates an erection effect that really resembles a natural erection altogether. So that's the beauty of it, that it really is something that doesn't seem really too artificial in how it's produced. Yes, it's a challenging thing to deliver in terms of the therapy, but the actual response is a very, very natural looking erection entirely.
Got it. Yeah, and that's important, because I mean, that's something that really comes up a lot in conversation and differentiates this from implants, right? Which work, they get the job done, they make the penis hard, you can penetrate, but it doesn't feel like that natural experience of having an erection, versus this, which kind of really does, just like the medication, the pills do as well. So it's an important thing for guys to understand.
Absolutely.
Now, as we know, in this world, there's no free lunch. What potential side effects or risks can we anticipate in guys using these medications?
Well, there are potential risks. Again, this gets back to understanding the balance of risk and benefit. The risks of the actual treatment now it can be side effects of penile injury. And principally, that's the thought here, that can take the form of causing a bruising effect. It can take the form of causing some scarring in the penis with injections that are done over some time in a repeated fashion over some months and years. A person's having sexual activity and may have to re-inject on many occasions. Some men do develop some scarring. And then the other risk that we certainly think is one to be very much aware of is having an excessive effect where the erection is prolonged. We use this word priapism. Now, how often do these things occur? Well, the bruising effect, I think, is likely to be, again, uncommon if its technique is done well. And if it occurs, generally it's a bruise, and you'll see kind of a purplish discoloration almost beneath the skin, maybe a little swelling. And generally, that'll just heal and be fine. But again, I think it's a function of how well the technique of doing the injections is. And if that's done well, those are very uncommon events. As far as scarring in the penis, that is something that also is relatively uncommon. May relate to how frequently a man injects. It may also relate to just different men having tendencies to develop scarring, but it may still be in the order of less than 5% at most, maybe even the 1 to 2% range of developing kind of a thickening effect, maybe some scarring effects in the penis that can occur. So those are kind of the local side effects aside from the tenderness and things like that, which is just going to be brief and hopefully not a long-lasting sort of thing. The other big one that I think is, I'll just refer back to then, is priapism. And I think this also is largely preventable, again, with counseling, with demonstrations in the office, proper dosing. Patients need to be educated well, that if an erection does last excessively long, and we see the ads out there with oral therapy. If you have an erection longer than 4 hours, go to the emergency room. Well, same sort of thing applies here, but in-office testing may help guide a man to have an erection that's firm but goes up and goes down within an hour. If we have an erection that's as long as 4 hours or even longer, we have conventionally thought that there may be an issue of lack of circulation within the penile tissue with this more prolonged erection time. And with that, this can cause not only just pain in the penile area, but tissue damage from lack of circulation for that excessive erection. So all those kinds of events, priapism events, we do want to avoid. But again, I think this comes down to early the demonstration of how to do this properly, dosing this proper, not using excessive dosing, and so forth. So I think that these are the main issues that we've at least want patients to hear and avoid.
So, guys hear this a lot. If you get an erection that lasts more than 4 hours, go to the emergency room, as you said. So just maybe at least on a high level, if you can pull back the curtain a little bit and say, okay, what happens when they do go to the emergency room in 4 hours? Like how do they get treated for that?
Sure. So if that did occur, then we have within our arsenal options to reverse the drug effect. Ideally, that's what we try to do. There may be some agents that we can locally deliver, again, with a tiny diabetic needle injection that can almost be an antidote for the drug effect that caused vasodilation. So there we want to reverse that and cause vasoconstriction, or make the blood vessels go back to their flaccid state, or just tightening back up. So we have drugs that can do that, but again, that may require injectables, again, that we'd have to do with careful monitoring, because some of these drugs have to be done with monitoring. That they can have potential risk to circulate within the body, and we have to be very careful with that. And if we have to go one step further, sometimes we do have to do some form of drainage of the penis. I don't want to be too graphic for the audience here, but there's ways that we actually go about drawing out blood out of the penis with the penile block to numb the penis, so it's really safe and hopefully at least traumatic to the patient to get the penis back to a flaccid state. So those are our initial treatments that we try to do if we have to go that far.
Got it. Just to double click a little bit, you had mentioned the scar tissue too as a possibility. Is that going to cause that scar tissue going to cause that curvature, like a Peyronie's type of situation, or what's the outcome of a scarring if somebody's like injecting in the same place and they may form a scar on the penis?
Well, scarring can have a whole range of effects. It could be just a minor kind of just thickening effect, where the penis is otherwise largely physically intact and not really surprisingly deformed. Others, it can actually be scarring, whereby it does create a deformity effect, whereby the penis with subsequent erection, the kind of inductions can show an angulation or lack of the proper lengthening and expansion in a normal looking direct penis. And it can create some sort of deformity if it's very severe scarring. In my years with injections, I always inform patients about this risk. If they start to see scarring or feel some scarring, the thickening in the penis, we may have to have a thorough conversation then that maybe this is a therapy that we may have to pull back on or do less frequently, or even just discontinue for fear of causing more scarring. So we have to have a conversation about that and understand whether continuing on with the therapy as much as it may be desired may be really inadvisable in that particular patient.
You got it. And so in your experience and in the literature, like how effective would you say that these injections are as a treatment option for erectile dysfunction?
Well, I think overall, the literature would bear out that more than 90% of men, maybe not 100%, because nothing's ever complete, but really almost all men, we can find a effective formula for you. It may be that monotherapy. In other men, we may have to go to bimix or trimix, and that's a super high test. And maybe some men require that super high test, and you can get an erection effect with that. So it really captures almost all men to have this opportunity to respond. There may be occasional men where their erectile tissue just does not respond well to the pharmacologic drugs. Maybe the damage within their penile tissue from the underlying disease state that they're dealing with, but be it diabetes, cardiovascular disease, or what have you, is such that the drugs just aren't working. Sometimes we may even do a combination. We may get into this where we do an injection with kind of a constrictive ring at the base of the penis. And therefore we can do all these other strategies to try and at least have something that a man can use to remain active sexually rather than have to commit to a penile prosthesis. But by and large, we can almost capture all men with the likelihood of having some benefit from injection therapy.
So that's interesting. You said the combination with the penile ring, the constriction ring. Another thing that's often circulated around the internet circles is the combination of using injections like Bimix, Trimix, but using it in combination with pills like Viagra or Cialis. Have you heard about that? And what are your thoughts on that combination?
I've certainly heard that, and that would almost be projected as, why not throw everything at the penis as short of surgery if you can. The concern here is that the oral medication, the so-called PDE5 inhibitors, sildenafil, tadalafil, vardenafil, evanafil, all these oral medications really are very similar to one of the injectable drugs called papaverine. And if you're using Trimix, you more or less are already maxing out the mechanism by which these oral therapies would work. And it's almost like, if you got a cup of coffee or put a heaping spoon of sugar in there, you can put, 2 or 3 more heaping spoonfuls, and there's not going to be a whole lot more sweet than that. So either you can taste it or with that amount of sugar, or you're not going to taste it at all because maybe the taste buds are just not tasting that. So really, it's almost like a redundant treatment that it's already been maxed out with the high level injections, whereby oral therapies would unlikely offer anything additionally to that treatment regimen.
Does the addition of oral therapy add additional risk, like of priapism or other type of risks, or is it just basically just really not doing much?
I think it's really more the latter, that it's just not likely to have any real true pharmacologic benefit, which would then fall in line with that patient really having a poorly functioning erection mechanism. His natural tissues just aren't responding, and if they're not responding well to almost maximal injection therapy, trimix, and even we've also even used this word quad mix with the strategies and other drug that may or may not, according to much literature, offer anything more. Then that's almost then with the fourth drug or even oral therapy, you've just almost maxed out what the drug effect can even offer with that man's erectile tissue.
Got it. Now, a couple of questions on timing. If a guy uses a dose, whichever dose of Bimix, Trimix, whichever one he's using, and let's say either he doesn't get an erection or the erection is just not up to snuff, can he re-inject right afterwards to try to increase the efficacy?
Well, it's a good thought, and there's always that consideration that you're in the middle of a sexual situation, you want to really respond well. You're not responding there, why not just re-inject? In my practice, I have conventionally told patients that would be something to avoid. There may be a delayed effect from the initial injection. Injecting more medication may be the equivalent of excessive dosing, where you could get a prolonged erection effect. And so it's potentially at risk. And so I've conventionally said if it doesn't work that day, maybe on another day, proceed with an injection kind of situation and see what might happen. If that's happened on a couple of occasions, hopefully it's not too much frustration that we need to have a conversation about how we make a dosage adjustment, or maybe even go to, if that was monotherapy, go to like Bimix, Trimix, or escalate the treatment regimen, but doing under some guidance. So just repeat injection right away, I think it's potentially fraught with an erection that could be prolonged, a priapism might be induced.
Got it. And in the same vein, from a reasonable perspective, how often could or should men be using the injectable therapy? Is it something they could be using a few times a day, every day, every other day? Is there a magic number, or is there a safe magic number, I guess?
Well, good thought. And I don't think there is really a safe magic number. I think many of us in our specialty have said injections should not occur more than once daily. And perhaps that's just a safe thing to do. Whether somebody can get away with an injection in the morning and then maybe do something in the evening, calling that another day later, if you will, it could be considered because you're on your vacation and you're having this honeymoon and you really want to get busy. Well, I can understand all of that. But again, it's just a matter here of just trying to be safe, trying to take precautions that you don't possibly cause a priapism effect. So anything within hours, I think, may still be a few hours or even several hours might be at risk. That's the main message to hear, I think.
Got it. And then a question that guys often ask is that, are these injections something the body can get used to, meaning like it becomes almost immune to them, where they need higher and higher and higher doses and then it just stops working? Is that something that you see a lot in your practice? And if so, what would that be caused by?
Well, this concept about how taking drugs repeatedly have a lack of effect, almost equivalent to somebody who's drinking a beer every day and doesn't get drunk even when he wants to take a six pack. As if there's some sort of mechanism, and we have this term we use, tachyphylaxis, that refers to just how drugs lose their effect. But I think that the likely concept is really something different. I think the likely effect is just that over time, and maybe over a couple of years, a man's bodily function, his cardiovascular system, may actually be changing and becoming less strong, if you will, less potent, less functional, and therefore the erectile tissue, which is part of the cardiovascular system, which is a blood vessel system that's localized to the penis, may actually just be evolving, be it from an underlying disease state or what have you, and therefore just the responsiveness to the therapy is becoming diminished. And so more than likely that's the explanation that's in play.
Got it. And in terms, just a little bit more in terms of logistics now. So again, you go to the doctor, they prescribe Viagra for you. You go to the pharmacy, they have it on the shelf, they put a few pills in a bottle and you're off to the races. Is it as simple with injections, or is there more to it in terms of these injections? Are they sitting on the shelf, or do they require a little bit more preparation? Is there any more in terms of thinking about how they're stored, anything special about them because they're a liquid form versus just pills in a bottle?
Well, certainly our pharmacologic colleagues, the the individuals who run the drugs, the pharmacists and that sort of thing, the drug shops, have certainly helped us out here. And with the scientists and then the pharmacists, we have tried to strategically bring forward options for our patients. The reason that this becomes a topic is if it's made up as a drug in a vial that we aspirate some fluid in and inject as a patient, let's say, there is a concern that the medication could lose its efficacy over time, may not be quite as effective, may lose its potency like spoiled milk in the refrigerator. And so that is a concern. There have been formulas made up of reconstituting these medications. That is, they can be kept in such a way that they're powder form. You can reconstitute them almost like concentrated milk. Again, using the milk analogy, and therefore a patient doesn't have to worry about the pre-made or pre-prepared solutions that can expire. And so these are all options. I think it does come down to really what the manufacturers can produce, what different pharmacies men have access to. I think we all have seen that this field is constantly changing with regard to manufacturers producing some of these drugs. So it may come down to just what's available for patients in different locations. But historically, in the past few decades, we've had all of these different options with the knowledge that, yes, the medication can expire if it's just sitting on a shelf for a prolonged period of time, many weeks, let's say. Some can have some greater duration of benefit if they're refrigerated. So I mentioned that, and follow pharmacy recommendations if you can do that. Understandably, some patients don't want to keep it in a refrigerator if other family members may see what's going on with what that is and what's that drug, what's that doing. So for discreetness, the patients may elect to want to use something they can reconstitute when needed, but that could be a little more tedious. Along the lines of treating erectile dysfunction, many may find that they want something a little more spontaneous and just not too tedious to do so. But there's trade-offs in all of this, and for discreetness' sake, if it can be reconstituted, just kept in a drawer and used when needed, that would be an ideal option for some patients.
Perfect. And last question, and we kind of touched upon it. What happens if, despite all our best efforts, the injections just don't work? What in your practice, what's your next tool or your next arrow in your quiver, if you will, for men who's, they've tried pills, they've tried injections, both haven't worked. Anything else we can do outside of surgery at that point?
Well, certainly we touched on this a little bit, that some men can do injections, maybe with a constrictive band. Again, this is within the range of intermediate therapy without having to go to surgery. These are strategies that can be used here. I know that there's some other therapies out there that maybe your audience has heard about, from shockwave and platelet-rich plasma and all these sort of things. These things remain investigative, just to say them frankly, and whether they truly can be beneficial in many of more severe forms of erectile dysfunction is really in question. So I think just what we have is our more conventional therapies, maybe combining injections with vacuum therapy or with constricted band, maybe some additional strategies to consider.
Perfect. Thank you very much. And now switching gears a little bit, although not really, because I know you cover this a lot in your book. Let's talk a little bit about your new book that I'm very excited to chat about, and I had the pleasure of looking through before our conversation here, called The Manhood RX: Every Man's Guide to Improving Sexual Health and Overall Wellness. And I personally know you've provided a wealth of knowledge both to the urological community as well as to lay people in the field, just regular men who have problems. And you've written a lot of stuff before. What inspired you to write this particular book?
Well, what inspired me was just the sense that I think patients in the community or at large, the lay public, could benefit from a resource that I think is much more accurate, straightforward, tells the truth, gives them a sense of what's really available, helps with addressing the taboo subject of their sexual dysfunction in an informative way. And I realize that I perhaps have made contributions to the field in many ways. As I mentioned, being a leader in the field with guidelines and directions with other specialists where we want patients to hear the truth about what's available and how they can address their sexual dysfunction as part of their overall wellness. I've also had some contributions to the field with the original science behind the oral medications. In my laboratory 30 years ago, had really described the science of erections from which the oral medications are even based on, and we figured out how erections even work. So I thought that perhaps if anybody could kind of put something together, put it out there, and have patients really feel that they could trust a real authority in the field, then perhaps I could be that person.
No, I think that's great. And I really enjoyed looking through the book. I enjoyed a couple of elements of it. One was that you really tie together, it's not just about sexual health, right? It really provides a much more holistic view of the relationship between, first of all, sexual health and overall health, which in men is becoming more and more of a hot issue in terms of, sexual health even as a barometer for overall health, right? In terms of it's not an isolation. Your penis is attached to the rest of your body, and it is a function of that. And maybe if you can share a few words about that holistic approach to sexual health that you describe in the book as well.
Well, I'm glad to offer my thoughts with regard to that. As you mentioned, your erection response is a barometer of your health. I mean, that sounds kind of bizarre, but in point of fact, the erection response is kind of an aggregate of blood vessel function, nerve function, hormones, chemicals in our bodies for how things work, the metabolism of our bodies, and so it's certainly been a very good clinical observation where we've actually understood that men who lose their erections start to have cardiovascular diseases, metabolic diseases, diabetes, and others. Those who don't have those or correct these conditions, they tend to get their erections back. So it became very clear that your erection status is a great gauge of how you're doing health-wise. So for the audience, if your erections are starting to change, certainly we want you to be sexually active for the aspect of one's interest and pleasure of life. But at the same time, that is something that ought to be a clue to you that maybe, bring it up, discuss it. And if you've not had a wellness check, get that done. This could be really a gauge for how well you're doing with your overall health.
Yeah, I think that's just so important. And I think that, your book in many ways parallels, the goals of your book very much parallel this podcast in the sense that I love the way that you organize it, right? It wasn't just a question of, okay, now I'm going to talk about erectile dysfunction. Now I'm going to talk about premature ejaculation. Now I'm going to talk about penis size. You actually, like your chapter headings, like for instance, erectile dysfunction, it says erectile dysfunction when it doesn't work, right? Or priapism when it occurs too soon, or low libido when I'm not interested in sex anymore. I think that's really valuable because, again, for busy guys and stuff, when they're looking for answers, it's fantastic. It's like it kind of serves like a guidebook, right? That they're not just reading this as a novel. As a urology resident might read and say, I need to learn about urology. They're saying, listen, this is the problem that I have. Here, I found it. I'm not interested in sex anymore. And you dive right into that chapter and you provide this great, high level and in some ways detailed experience of like why and what to do about it, which I love because, again, you're not trying to treat people with this book, but you're trying to increase awareness because and I'm sure you can comment in your own practice. In my practice, a lot of guys feel very reluctant to go to the doctor. They feel very nervous in talking about sexual and other problems. And when they think that this is only happening to them and they don't know how to address it, they're embarrassed to address it. And when they see it in print or they hear experts talk about it, all of a sudden they're like, I'm not alone. And that gives them that courage to be able to go talk to their doctor about it and say, you know what, I read Dr. Burnett's book, and you know what, he says, if I have this problem, I need to do X, Y, and Z. And that's kind of why I started this podcast. That's why it kind of gives me great joy to see that in the book that you wrote, because it really empowers men to take control over their health.
Well, I can only echo those comments, and I compliment you for also doing this podcast and then just trying to help shake the taboo out there and maybe reframe all of this in a way that patients know that it can be accepted and addressed. And that's what the book attempts to do. The podcast, I think, achieves the same. And congratulations while you're doing that. I want men to recognize that we want them to be full as men. I want men to feel that they are functional, that they sometimes don't, can't have these conditions arise. And rather than just kind of, put the head in the sand or try to deny it, let's see whether we can address it. And so we can provide information through whatever media that we're doing, books, podcasts, bring out the good information and improve their sense of wellness and their mental health too, and the sense of who they feel as a man. I want men to feel that way, and that's what the purpose is behind all of this.
Thank you so much. And we talk about wellness, we talk about overall health, and part of wellness is, again, leading a happy, successful life. You, as they say, people stand on the shoulders of giants. You're one of those giants that many urologists have stood on the shoulders of. What is the secret to your success, both personally and professionally?
Well, gosh, fairly loaded question. There's a lot of elements to this. I think first it's just that a very supportive family, good upbringing, good sense that progress in life is relying on oneself to work hard and have a good work ethic and get educated. So I think that I learned that from my parents. I was certainly fortunate to be able to get some good schooling opportunities and just make the most of that and have good mentors, have opportunities with educational environments to achieve, and really just to feel that for me to honor the abilities that I have, that I've been given as a surgeon, as a scientist, as an educator, as a mentor, as an ambassador, as an advocate for patients. I just feel that every day of my life I just want to try to get out there and do a good job. So that's really what it's all about.
Truly inspirational. Dr. Burnett, thank you so much for your time and for your insights. Congratulations on your new book. We wish you all the best and with it. And I know that a lot in my audience will go out and get it because it is a fantastic resource. And to all of you guys watching out there, please remember the mantra of our podcast here, that your best life is a journey and not a destination, and use every single day to get just a little bit better. We'll see you all next time.
Thank you, Oleg. Take care.
Thank you.